Okay, why choose the anterior approach? I think that's the first important part. As an armamentarium, many different choices. It's intermuscular between sartorius and tensor fasciae lata. That exposes the intermuscular interval, and internervous is between the femoral and the gluteal nerves. Muscle sparing, you can have easy bilateral hip replacement, easy recovery, more important for short stay or a daycare surgery also. The fundamentals are more important. It gives you coverage in diverse BMI, heights, gender. Every place you can use this surgery. You have to identify the tough to the easier cases. If you have a GT outside the ASIS, that's an easy transition. So table preparation, I am going to show you on the table-less, the normal table. But you have to remember the break of the table has to be where the perineum or the pelvis has to lie. You can increase the width on the contralateral side where adduction has to come on. The patient preparation, he lies straight on the bed. Prepare the patient from the umbilicus level to the feet. Use bilateral stockinets, and what I use is a bilateral TKR drape to prepare both the hips simultaneously. Instrumentation is standard or specialized instrumentation. I would seriously recommend there is definitely a role for specialized instrumentation if you want to handle more surgeries. You want to have special offset graters, offset punches, these kind of retractors, biprong retractors with large lever arms for an easier propagation of these surgeries. You need to have these offset instrumentation if you want to be easy and not to have a soft tissue hampering. As discussed initially on the digital auto hip templating on AutoCAD, you can identify which plant you are going to use, which implant you are going to be using on, and what is the position of the cup, what is the shortening you need to cover up, you need to have a neutral or an offset liner. So in all those conditions, you have a variability, you can have your assessment done beforehand. Now moving on to the surgical technique, the patient is prepared. The incision starts from 1 to 2 centimeter distal and posterior to ASIS. It's along the direction of the tensor fasciae lata, 8 to 10 centimeter long. You can have a myoclonic contraction of the TFL to identify where is the TFL, 8 to 10 centimeter long incision. Once you master this, you can even go back with a smaller incision in thinner patients. Identify the muscle belly of TFL. Have you changed it? You have gone back. Okay. So what you need to identify is, here there's something else going here and something else going there. Okay. You would identify the lateral femoral cutaneous nerve of thigh and the lateral circumflex vessels need to be coagulated. So very important tip, once you take a blunt parameter, you have to reflect the reflected head of rectus femoris, reach to the anterior capsule, do an anterior capsulectomy or capsulotomy, whatever you want as a parameter. Your exposure requires special equipment at the inferior part. This is the anterior capsule that we are taking off in a fibrosed condition. In a lot of other conditions, you can just make a window to keep the anterior hip capsule, which you can stitch back. So there is a special position in which you put in your anterior retractor. It does not move on to the contralateral hip, it moves on to the contralateral kidney rather. You form a double osteotomy, a napkin ring osteotomy, take out a wafer of bone, and once you have the head, put up a corkscrew, lever it through and take out the femoral head. So once the femoral head is out, the acetabulum is not very tough because the acetabulum lies in front of you. It's only the positioning of retractors which you need to muster up in different conditions. So these are bipronged retractors moving in around the obturator part. So when reaming, keep the limb externally rotated around 60 degrees. And if you have a difficulty putting in the reamers, just put the reamer in, then attach the coupler to it and go in for a sequential reaming as in a normal hip case. Till the time you achieve a good anteroposterior capture of the hip, put up a trial component. You have a tendency to put your cups more in anteversion and inclination. So be aware of this possibility, and you have a tendency again to ream the interior part of the acetabular wall. So all these things are very, very important when you are reaming your acetabulum. So like in a normal hip, since you have a supine position, putting in the hips in the right kind of anteversion and inclination as we know on with the safe zones, the screws can get on if needed. So your definitive cup goes in as a philosophy, you want to put up the liner as a neutral or a lift right now, or you can put a trial inside, that depends on what philosophy you move on. Femoral preparation is the key that you need to understand in this. So femur needs to be retracted laterally and out. The flip-flop technique is extremely important to pull the femur out of it. Break the table to around 15 to 20 degrees of hyperextension. externally rotate and adduct the limb in a cross leg position. You have already done the anterior release. Now you have to go in for inferior and superior release. This is a very important marker. If your femur does not move out and it gets stuck beneath the acetabulum, you're going to having a terrible time. So release the inferior capsule and put up a bone hook, lever it up and out. So this is a marker to see, and you put up a bipronged retractor beneath the GT. This exposure is one of the most important part. Was free mobilization of femur in anterior lateral direction is a must that you must have. Create a neck on the superior capsule and you will see a fat protruding between the capsule and the gluteus minimus. Once you have that, you put a bipronged retractor, you will lever the femur out of the loop. Then you have a box osteotome where the saddle of the bone needs to be removed on the middle part of the greater trochanter. Go in a sequentially increasing size of the broaches. Here two things to important, very things to keep in mind. One, you don't perforate the cortex. Second, you have a tendency to put your components, terminal components in varus. These two things are very important. In the beginning cases, I would suggest always keep an image intensifier with you, both for the acetabular positioning as well as the femoral positioning, that you are not perforating. Once you put up a definitive broach or a trial in, you do your trialing. It's very easy in sort of a supine position to see the level of the malleoli, the ankle, the knees, and to know that your limb length is restored. You can trial on different head neck combinations as the offset planning that you have done initially in the trial templating. Put in the definitive component. As you saw out here, there is a tendency to keep these components in varus and proud. These things need to be checked onto this image intensifier. Once you have done your definitive component in, again going for a trialing, see the amount of combined anti-version that you have with these components, your stability, your levels of impingement, then put in the definitive head. So once you put that, you can see your range of motion. The paramount part and the benefit in this thing is you want to control the limb length discrepancy, which is way easier with the anterior approaches when the patient is lying supine. X-ray confirmation is normally, I would say, important in the initial cases, so you do not do mistakes. Select your cases well initially, and once you have mastered this technique, you can go on to a diverse circumstances. Closure is a surgeon preference. We use subcuticular sutures. We make them walk with all these blocks 3 hours after surgery, and a couple of them on the same evening or the next morning they are discharged. So I would advocate for DA in special cases, but learn it well. You can easily do it with a normal table without using those specialized HANA tables also. Thank you.